Hello there and welcome to another episode of Dollar Store Surgery. In this episode, we show you how to replace an arthritic knee with an artificial joint. The patient is the leg that was built in a prior episode. As always, the material you need are listed at the end of this video. There is also a somewhat quirky student version of this episode as well. Enjoy the video. The overall process is to make 5 cuts on the femur and slab cut and drill the tibia so we can implant the artificial joint shown here. Now to access the joint, you'll make a straight line incision over the middle of the front of the knee. Patients, when they look down at their knee, like to see things centered. Once you've got the skin out of the way, you can actually make the more interior cuts wherever you want. And the cut through the capsule is through the medial side right along the patella, hence it's called a parapatellar incision. And the reason we do this is that you can now straighten the limb, flip the patella over, bend the knee, and now you're looking right at the tibiofemoral joint. You'll also notice that we've cut both cruciates. The implant that we're using replaces the function of both the anterior and posterior cruciate ligaments. There are designs out there that rely on the PCL being intact, and there are new ones coming out that will rely on both of the cruciates being intact. Here is the slab cut on the tibia, and it might be best to start off with this cut. The reason is that the cuts on the femur can be a little bit more challenging, and once you remove a slab of the proximal tibia, you have more working space to work on the femur. Now, as you make your cut, be very careful that you don't injure the collateral ligaments, because now that the cruciates are gone, one of the main set of structures that hold the knee joint together are those collaterals. Also make sure you don't tag the patellar tendon or it go through the back of the capsule and hit the popliteal neurovascular bundle. Now, as always, vacuum up the particulate that's formed by all of these processes. You can see here cuts being made to the distal femur, and there are basically 5 straight line cuts. Now, the distal femur obviously is curved, and by making those 5 cuts, we can kind of make a representation of what a curve looks like with several different line segments, 5 in this case. And there you just saw that they were doing a little dry fit to see how well the femoral component fit onto the distal femur. Here's our group of surgeons working. We usually use groups of 3. Sometimes we use groups of 2. 4 is typically too many. And you can see here where the vacuum is being used to suction up all those little bits of particulate. Lots and lots of dust and particles are made during this process. Every time you pick up a saw or a drill bit, you're making a mess. And you can see it all kind of forming there at the bottom of that cut right there. So here this student is making a cut to the distal part of the knee joint, the proximal tibia, and cutting off that, oh, there it is, just like a little door. It opens up and you can see the exposed cancellous bone below. Now here we're looking at where the cut is and then where we're going to want to position the implant. It's important to get that patella out of the way. Sometimes it'll flop back into place. But here you can kind of reapproximate the joint, look at where that femoral component sits, and notice that there's those 5 flats on the back of the implant, and you're going to match that with 5 straight line cuts of your own. And that, they've found, is kind of the best way to preserve as much bone stock as possible and still get the implant to sit securely. You can use a variety of things. You can use saws. If you want to use a very coarse file, that works as well. Here students are taking the drill motor and they're drilling down into the proximal tibia, the cancellous bone there, and they're doing that so that the keel or the extension that comes off the bottom of the tibial component has somewhere to reside. And it was discovered during the development of knee joint implants that if you just replaced the slab of bone you removed with a slab of implant, the implant would not be stable. Maybe that's not too surprising. You need to anchor it more deeply inside the bone, kind of like how the femoral component is anchored in a hip joint replacement. So in this case, that keel or extension that comes down below the tibial implant fits inside that cavity that they're forming right now. And it's going to take a little bit of back and forth, a little bit of fitting and drilling, and you kind of want to slowly move to the point where you've created the right size cavity. You don't want to take out too much material and then have a very poor fit or a loose fit. So here these students have done a dry fit before they've used the cement, and now they've gotten the cement and packed the cavity, put some under the implant, And you can see both the tibial component off there to the left and the femoral component to the right, and how that cement kind of oozes out between the bone and the implant. A finger is a great way to remove all of the excess cement. An instrument can be used, of course, as well. And you can see how it really stretches on that capsule and how important it is to get that patella out of the way, or else it's difficult to get proper exposure. Now the students have reduced the joint, and they're able to now straighten the limb, flip the extensor mechanism back over, pull the instruments out, and ensure that they've got the proper kinematics. And one way to test that is to now just flex the joint back and forth.